Okay. Well, welcome. Thanks for coming. Today, February is the month for awareness for women heart disease. February 6th is particularly, we're trying to wear red to increase the awareness among women for the heart disease. Thanks for coming and thanks for beating this weather. And I hope that at the end you will feel that this was worth it. So topic Weir et al., women and heart disease. So initially from a long time, we have thought, and this is common perception among the public, that women are relatively immune to heart disease. And initially the heart disease is essentially considered as disease of males. But that's not the truth. This is the statistics, American College of Cardiology, AHA statistics about heart disease. So I will see that this is the total cerebrovascular disease, and blue bar represents the heart disease, and this purple bar represents all-cause cancer. So heart disease alone, you can see that it supersedes all the deaths because of cancer. Heart disease is even, there are more people dying from heart disease than compared to all cause of cancer. And as patients more than 85 years of age, the incidence is definitely supersedes, and under 85 year of population, again it's almost equivalent. So the red bars is comprised by stroke, and the green bar is all other cerebrovascular disease, which includes peripheral vascular disease and thoracic aneurysms, abdominal aortic aneurysms. So facts about heart disease. So heart disease is the leading cause of death among both men and women in the United States and throughout most of the developed world. In the United States, 1 in 4 women dies from heart disease. What's the prevalence of coronary artery disease? 5.8% of all white women, 7.6% of all black women, and 5.6% of all Mexican American women. Other high-risk population, immigrants from South Asian descent. Also, with the change in diet, it was thought that Chinese are protected, but most likely not. They are also at risk. Again, as I discussed, heart disease is not a man's disease. Approximately same number of women and men die each year of heart disease. And why this talk? Why this effort for awareness? Only 54% of the women in a survey by ACC-AHA, only 54% of the women recognize that the heart disease is #1 killer. And almost 2/3 of women who die suddenly of coronary artery disease have no previous symptoms. So all the more reasons that we should pay due attention towards what are the symptoms, what are the risk factors, and how we can be protected. I will briefly explain about the structure of the heart. So human heart has 4 chambers. Just focus on the left-sided diagram first. This is right atrium, right ventricle. On the back, which is not well seen, left atrium and left ventricle. So as you were talking about ventricle arrhythmia, so the lower part of the heart are called ventricles. If it starts beating very fast, if like 150, 200, more than that, it's essentially incompatible with survival. Heart needs time to expand, and if it's beating too fast, there is not enough time for the blood to come into the heart so that it can pump. So that to just briefly answer, that is ventricular tachyarrhythmias. But focusing on, in general, coronary arteries, basically heart is a pump. What its function is to pump blood. Right side of the heart, deoxygenated blood from all over the body. Lower part of the body from inferior vena cava come into the right atrium. From the upper part of the body, from a superior vena cava, come into the right atrium. Through this valve, it goes into the right ventricle. From right ventricle, it just gets pumped out to the lungs through this pulmonary artery. And from the lungs, the blood gets oxygenated, and in the back of which is not well seen, from the pulmonary veins, the blood comes back into left atrium, goes to the left side of the ventricle, left ventricle. Left ventricle is the main pumping chamber of the heart. It's basically responsible for pumping all the oxygenated blood throughout the body. That gives rise to aorta, and when it contracts, these valves closes so that the blood doesn't go back to atrium and it goes out of the aorta. Here there are arteries coming that supply the blood to the brain and arms, and it goes back all the way to the back through the almost to the pelvis, where it divides and give rise to the femoral arteries, iliac arteries that supply blood to the lower extremities. What's coronary artery disease? And just to make sure, there are two major coronary arteries, right coronary artery and the left coronary artery. Right divides into two, left anterior descending and left circumflex artery. So heart is basically a pump. It's made of a muscle that you can see. For proper functioning, it also needs blood supply. And where these coronary arteries are coming from? From very proximal part of the aorta, where all the oxygenated blood is going out of the heart. These coronary arteries come and they are right sitting on the top of the heart, and there are branches that go inside the heart muscles and supplying the oxygenated blood to the heart muscles. What is coronary artery disease? Basically, it's development of blockages, which is essentially cholesterol, inflammatory cells that seeps some, macrophages and all, all because of they create a plaque that's and it's very common. It starts forming even some of the newborns. If the mother doesn't have a good diet, then the fetus may have some streaks, like called fatty streaks, and they get progressed as depending upon what you do, what are your risk factors, they can get progressed, and they sometimes get so narrowed that it hampers the blood supply of the heart muscle. And one of the plaques, which may not depend upon its severity, if it's not, it doesn't matter if there are 90% blocked or 10% blocked. If it ruptures, if this content of from the blood vessels comes out, this is thrombogenic. Thrombogenic means that it's going to adhere to the blood, and the blood is going to clot, and it's going to acutely clot over that plaque and can block the blood supply of the heart. So as you can see, that specific arteries are supplying blood to particular areas of the heart, and there is no cross connection essentially for most part. And if these arteries gets blocked, it gives rise to heart attack. Part of the the artery distally, if the artery gets blocked here completely, this part of the heart is going to die, and that's basically results in the heart attack. What's uncommon in women? Coronary microvascular disease. If the person has a heart, is getting chest pain, goes to the emergency room or goes to the clinic, get essentially testing done, and they say that all arteries are clean. What exactly is that? This is also called syndrome X. Affects small arteries that supply the blood to the heart muscle. So what do I mean by small arteries? For most of the time when we go to the hospital, the catheterization, the angiography they are just going to show these arteries, which are lying, the big arteries that are lying on the top of the heart. But if there are further branches, they are going into the muscles, which are not seen. They are microscopic structures. So if there is a disease of that, then it's hard to diagnose. There are not that many diagnosis modalities. I think cardiac MRI remains one of the diagnostic tools that can be used in that. But unfortunately, this condition is more seen again in women population. And as I mentioned, standard testing that is done for the heart disease fails to diagnose microvascular disease. You can go through the stress test, you can go through the coronary angiography, but still the symptoms are there, and even it's hard to diagnose, doctor doesn't know, and the patient, it's equally frustrating for the patient that we are not able to get diagnosis. And it's linked to drop in estrogen levels in addition to the other coronary heart disease risk factors that we are going to talk about later. Another thing is broken heart syndrome. What's that? Also called as stress-induced or Takotsubo cardiomyopathy. more frequent in women. What extreme emotional stress can lead to severe dysfunction of the heart muscles. So arteries are completely clean. There is no good reason that why patient will come still will have it. The presentation will exactly some like a heart attack. They will come, they may have EKG changes, they may have a blood test, may show heart damage, but arteries are again clean. And those form of, are most commonly precipitated by, stress or sudden like death of somebody in the family or other major stresses. But good news is that if you have Takotsubo cardiomyopathy, most people will completely recover in weeks to months. Coming to the point, non-modifiable risk factors for heart disease that of course you cannot do anything about that. Age, as we know that as we age, our risk for heart disease increases. Till the menstrual cycle goes on, premenopausal women are essentially protected to some extent, but you can defy those odds by what you do, what your genetics is. But again, the risk of heart disease increases after menopause significantly. If you have a family history of premature coronary artery disease, race, African American women, Mexican women, again the women of South Asian descent are increased risk. Preeclampsia, what's that? It's basically pregnancy related in the second or third trimester, mostly diagnosed. Diagnosed, features are high blood pressure, damage to the kidney, dysfunctional platelets, and some dysfunction of the liver, and lot of albumin or protein in the urine. The treatment is delivery. There is no definite cause known, but preeclampsia leads to further risk of heart problems, and they may have high blood pressure later in life. Gestational diabetes mellitus or gestational diabetes during pregnancy. So it's a major risk factor for diabetes in the later part of the life. What we can do about what are modifiable risk factors? Smoking. So again, this is one of the things that absolutely related. In multiple trials has been shown that smoking is increases the risk of heart disease, high blood pressure, stroke, high cholesterol, blood cholesterol levels, diabetes and pre-diabetes, metabolic syndrome, which is again increased body weight, insulin resistance, overweight and obesity, lack of physical activity, unhealthy diet, stress and depression leads to lot of inflammatory, it's essentially predisposes to the inflammatory, generalized inflammatory condition in the body. Sleep apnea has been shown to be linked to multiple arrhythmias and also high blood pressure and coronary artery disease. Oral contraceptive pills, this remains a matter of debate, but it's known that it increases the risk in women only who smoke, but it's not clearly known if you are non-smoker what it does, but the women who are smoking and using oral contraceptive pills are at risk. Anemia. So what exactly anemia? What exactly I mentioned that heart is a pump, and if what exactly is pumping the blood? If the blood, what the blood does, it carries oxygen, all the nutrients. If the blood is, and if you're anemic, there are not much hemoglobin in the blood, heart has to work harder, and in the long run, it can lead to cardiomyopathy. Symptoms of heart disease. Some women, as I mentioned, may have no symptoms. Women may not have classical angina. So what exactly is the classical angina? So the textbook is, you will get a chest pain on the left retrosternal region, left side of this sternum, and the second characteristic, it's exacerbated by exertion. When you do something, the chest pain is going to come. And the third characteristic is it's relieved by rest. It may go away when you're not doing anything. Or if the pain comes, you stop doing what you are doing. But women may not have that classical angina. Chest pain, classically that's described as a tightness or pressure-like feeling, but in the woman it may be dull, heavy to sharp, or just discomfort. Essentially may have pain in the neck, jaw, throat, back, interscapular region between in the upper back, even upper abdomen, left shoulder or left arm. Triggers for the chest pain, as I mentioned, again the classical angina is with exertion, but in women it may be physical activity or even mental stress. If you are, like patient will come that you are with the argument with so and so, I had chest pain. That's a sign. That's a sign. Fatigue. You may not have chest pain. Just the fatigue. You may all the activities. Oh gosh, I'm getting tired with the things that I used to do normally. It makes me tired. That's be aware of. That may be the sign of you need to see your doctor. You need to get checked. Shortness of breath. Again, with all this, shortness of breath remains the some patient anginal equivalent. Symptoms of heart attack. Again, some patient may not have chest pain at all. This most commonly in the patients who are diabetic. They may have very well known to have silent myocardial infarctions, chest pain or discomfort. Some may have heartburn, indigestion, nausea and vomiting, extreme fatigue, shortness of breath, palpitations. Some unfortunate ones just have, in the first even may have sudden cardiac death related to arrhythmias that are related to acute ischemia or the heart is not getting proper blood. Congestive heart failure. If the part of the heart gets damaged from the heart attack or from the Takotsubo or stress-induced cardiomyopathy or other forms, may have the most common symptom will be shortness of breath, fatigue, swelling in feet and ankles. The right-sided heart is failing, you could get swelling in the feet and ankles, legs. If it gets too overwhelming, then the abdomen will get bigger, you will develop ascites. Occasionally, the only sign may be cough and wheezing. And sometimes, it's not uncommon in clinical practice to see patients who have been treated for multiple months or even years that you have asthma. Until the patient gets admitted, somebody orders an ultrasound or echocardiogram of the heart, and we soon know the heart is hardly functioning. Arrhythmias, ventricular tachycardia is one of the part of atrial fibrillation. Arrhythmias, most common symptoms is palpitations, fluttering feeling in the chest. It may result in syncope, lightheadedness, dizziness. Diagnosis of heart disease, ECG is the most common, but again ECG may be non-specific, especially in women. Stress testing. What exactly is the stress testing? So what we tend to stress, it can be done with several ways. Most common is the walk a person on a treadmill. Why? So if the blockage, as I mentioned in the initial slides I showed, if the blockage, there is a significant reserve of the heart muscle. If the blockage is not significant, if the blockage is, let's say, in the range of 60 to 70%, when you do something, if the heart is not pumping that much, it doesn't need that much blood to function. But if you start running, you stress your heart. It has to pump harder to meet the body demands of the other parts of the body. And so to meet the pump harder and faster, it needs to take more oxygen for its muscle itself. So that may be, you can see the ECG changes during the exercise, or you may be able to see with the ultrasound that a part of the heart may stop giving up, it may stop stop contracting. That is with echocardiography. Echocardiography is basically ultrasound of the heart. It's very safe technique. This is main test by which we can diagnose. You can see exactly with the ultrasound what exactly the heart chambers. We can measure all the chamber diameters. We can look at all the valves, if some of the valves are leaking or if any stenosis. What are the blood tests? So troponins. Troponins are basically some very specific to, is part of the heart muscle, and it's only specific to the heart. If in the hospital, most of the time if anybody goes with a chest pain, they will check cardiac troponin levels. So it's supposed to be only in your heart. If it's seen in the blood, that means there is some damage to the heart muscle. So troponin is essentially a marker of heart attack. BNP levels. This is essentially a marker for congestive heart failure. This is the natriuretic peptide, which is if there is a stretching of the heart muscles, this levels of the BNP goes up, which is normally seen in congestive heart failure. Lipid profile, this is again in the preventive clinic, hemoglobin checking for diabetes, cholesterol levels, it's very important. Chest X-ray to see again cardiac catheterization and coronary angiography, which is again done to see if there are any major blockages. This is the gold standard test. If anybody has abnormal test or any clinical signs of presentation suggestive of heart attack, generally they will go right away from the ER to catheterization laboratory, and this will show us what exactly we put a catheter with and insert some plastic tubings called catheters that go to the heart and cannulate that coronary arteries that lie on the top of the heart that I showed earlier, and shoot some dye put through that catheter, and with the X-ray scintigraphy we see that how dye is flowing. If there is any blockages, it will show us on catheterization, and we can fix that. If there are any one blockage or in the acute setting, we can suction out any blood clots, we can put stents in, and if there are any major blockages or the major artery is blocked, then again there is an option of bypass and all that. But cardiac CT scan again also can be done to see the coronary arteries. Cardiac MRI is coming on for multiple, if there is inflammation in the heart, if there is again condition of hypertrophic cardiomyopathy, many valvular diseases. So there are so many indications for cardiac MRI. But prevention of what you can do. So this is the most important thing, that smoking cessation, absolutely. Aerobic exercise. So this is the aerobic exercise. What do I mean by aerobic exercise? Jogging, walking on a treadmill. And what's the recommendation? 30 minutes for most days of the week, you should do it. Healthy diet. In the crux, again there will be later in the lecture by the dietitian, but for the crux, simple carbohydrates are bad. See, what do you mean by simple carbohydrates? Plain sugars, sugary drinks, chocolates, anything, cakes, all that kind of very rich in sugar. Too much fat is bad. But again, there is a lot of research going on in this area. Still we are puzzled. Initially we thought that only the fat is bad. Now the focus is on simple carbohydrates. So I would say for the time being, till we explore what's the perfect diet for human being, simple carbohydrates and avoid too much fat. Decrease stress levels, cholesterol management. Some of this is part of cholesterol is genetic. It's very hard to, like HDL, which is good cholesterol. So if this, in some people they have low, and it's most of the time it's genetic. It's very hard to change it. But we can do, monitor the diet, don't get too obese, as the abdominal fat, which is considered the bad fat for the body, if it goes up, then the cholesterol metabolism and all that is altered. And adequate control of diabetes. So diabetes is, if the male has diabetes and female has diabetes, the female is at higher risk for heart disease as compared to the male with similar A1C levels. So adequate of diabetes and high blood pressure is important, and at last awareness that again women can be at a risk of heart problems, and this is #1 killer in women. Okay, so happy to take any questions. Again, if you did not have any blockages, that's somewhat reassuring, but again depends upon the risk factors. If the person is diabetic, if the person has high blood pressure, is a smoker, then catheterizations 10 years back may not be that reassuring. But if you have catheterization a year back, I think depends upon when was the catheterization and what are the risk factors that we are dealing with. Mm-hmm. Mm-hmm. Mhm, mhm. Sure. Sure. Yeah. So, every time I won't recommend catheterization. Every time we do, we know that, you had normal catheter arteries before. And I think in that case, only thing I think if you are concerned about any of the symptoms that I mentioned, fatigue, shortness of breath, chest pain or pressure, if you are not, then again you have to do what you can. You control other risk factors, high blood pressure, diabetes, and I'm not saying in your context, but I don't think the catheterization should be done for everybody. No, I don't think. The way to, if you are concerned that you may not have, you may have risk factors, then again, just go to the doctor, tell them that you are concerned, you are not able to eat healthy diet, what should I do? Maybe a treadmill stress test. Maybe just walk on a treadmill, let's see how much you go. And again, we routinely don't recommend in asymptomatic patients. If there is concern, if there is, mhm. Sure, sure. I don't think you need at maybe once every 5 years, but definitely I won't repeat a catheterization for sure. I don't think the catheterization, again, we are sticking catheters in the heart. In the normal arteries, there is at least any complications is rare, but again, your doctors must have told you that catheter, there is a less than 1% chance, but chance of death, arrhythmias, dissection, damage to the arteries. It's not a risk-free procedure. So I won't do it, uh, you know. I think the best thing that will be maybe exercise echocardiogram or just a plain treadmill test if you are concerned and if there are any symptoms. Of course, if the symptoms comes, if anything changes, then it needs to be evaluated. Sure. No, absolutely. If concerned, then again, that's stress test. But I don't think I would recommend catheterization in that condition. Again, as I mentioned, there is a lot of things that go into play. Other risk factors, what are genetics? Some people eat healthy and their genes are bad. Some people are, eat whatever they want, they don't get heart disease. Some people smoke till 90 years of age. So there is hard to, these risk factors that we talked about comes from large studies like thousands or of, from population studies. That this you can do, but for a one person, it's recommended that you should eat heart healthy diet, but if you cannot do, then of course you cannot do. I think you should see a dietitian. They may come up with something that is may suit your body. That's what I would recommend. That if something, some form of, maybe some preparation of vegetables or fruits that. Again, I won't get stressed about it. If you cannot do it, again, as I mentioned, yeah, yeah, stress and anxiety about not eating, so that's you are not helping yourself either. So, uh, yeah. So I would be, if I were you, I would be happy that I did not had any major problems when the catheterization were done. You can, of course, exercise, aerobic exercise. You can, Mhm. All right. Mhm, mhm. No, absolutely, it's hard, ma'am. It's hard. But again, rehabilitation doctors, they definitely there is some form of even with a patient with back problems, we do supine bike, or there is some form of you can twist things that is not going to stress your back. If you are really motivated, definitely there are things available that you can do. Yes, please. Yes. Mhm. Okay, so you have,
I had to go to the heart because my heart accident.
okay, okay. So what exactly, so she brought a point about atrial fibrillation. What exactly is atrial fibrillation? So atrial fibrillation, as I mentioned, I'm just going to go back to previous slides and we are going to look at the structure of heart again. Okay. So as I mentioned, the upper part of the heart are called atrium. So atrial fibrillation. So what exactly fibrillation means? So normally there is an impulse like a light bulb and a switch. When you turn on the switch, the light bulb glows. There is a focus in the right atrium called sinonodal SA node, or the impulse that makes the heartbeat most of the time comes from SA node. And first the upper part of the heart contracts, then the lower part of the heart contracts sequentially. Atrial fibrillation, instead of organized contraction, instead of one SA node beating, there are several focus in the atrium which are rapidly firing, and the atrium is beating at maybe 300, 400, 500 or maybe even more, the rate of the atrium. But the heart rate, there is a node called AV node between the atrium and the ventricle. That's the only way the impulse from the upper part of the heart can come to the lower part is through that AV node. And that's the basically a gatekeeper of, if the lower part of the heart starts beating at 300, 400, 500, as I mentioned earlier, that's incompatible with survival, or that's called ventricular tachycardia. So atrial fibrillation, so post-operative atrial fibrillation is very common. It's most of, it's again in the context of cardiac surgery and even other surgery, it's common. And most of the time, atrial fibrillation, as I would say, is a nuisance. It's a nuisance. It's technically, in most cases, it's not a life-threatening condition. Okay, but what bad part atrial fibrillation does? So again, I will take a step back. Human blood has a property that if it's keep moving, it does not clot. And when it doesn't move that well, it stays at one place, it tends to form blood clots. So in atrial fibrillation, the upper part of the heart, rather than normal contraction, they are doing like that. And the blood can, if you are in atrial fibrillation for a long time, then blood can form, their blood clot can form in the, and let's say if the blood clot forms in the left side of the heart and the heart goes back into normal rhythm, if that clot stays in the heart, most of the time doesn't cause problems. But if that clot goes out to the ventricles and through the aorta, so wherever is that clot is going to go, it's going to block the blood supply of that organ. If it goes to the brain, it can give rise to stroke. If it goes to the kidneys, it goes going to give renal infarction. Or if it goes to the coronary arteries, it can cause heart attack. So that blood clots are major problem with atrial fibrillation. What are the symptoms? As I mentioned, palpitations. What are the predisposing? Thyroid, again, obstructive sleep apnea, thyroid hyperthyroidism, obstructive obesity, overweight are the conditions. So what are for atrial fibrillation? So long-term effect, the upper part of the heart may get dilated in the long run if you are in atrial fibrillation for a long time. Even days to months. If it causes, let's say if it comes for 5 minutes, no, it's, if you had just had 3 years, but again you don't know the problem is. It requires event monitoring, or if you went into atrial fibrillation once, you can go back again. Your heart has easily, yeah, we know that. And again, if any of my patient has atrial fibrillation, depending upon the risk factors, they may have to take aspirin or may have to take blood thinners to prevent that thromboembolic complications. Aspirin, low dose or high dose, or again the low dose, again I don't think that makes much difference, you can low dose. But again, if there are other risk factors like high blood pressure, diabetes, or prior history of stroke or age, they may be a candidate for age more than 75 years. And it's known that these clot forming are more, yeah. And again, unfortunately, the blood clots with atrial fibrillation are more common in women. So that's another point that, so again, if you had atrial fibrillation just once in the setting, then again, you may not have, again, but you need somebody to put you a monitor. For what we do in, like, we send patients with monitors, and they may, long-term monitor for 30 days. You wear like this mic sort of device where the leads are sticking on the chest, and it's going to continue to monitor your heart, what exactly it's doing. And it will detect if it did any atrial fibrillation or not.
I got it off the track, or once in a while I got it off, well, they keep finding me if somebody was watching the chart.
Sure.
But it hasn't come back, and actually the cardiologist let me know here.
Okay.
So
Sure.
he said he would be around if I needed.
Sure.
It's been 3 years.
Absolutely.
Basically, I had a healthy heart.
Sure.
You know,
As again I mentioned that it's a nuisance. It does not cause major problems, except when the atrial fibrillation is uncontrolled. Your heart beats in a long run. It continues to beat, fast. Then it may give rise to congestive heart failure. But and one thing that I would definitely mention, that obstructive sleep apnea is strongly associated with atrial fibrillation. So if you have atrial fibrillation, you need to get tested for obstructive sleep apnea.
you mean if you had it, if you don't have it now, you consider not
I think
having
consider it testing. If you had atrial fibrillation, consider it getting checked. Yes. Mm-hmm. Absolutely, absolutely, absolutely. So again, first of all, again I would, so high dose aspirin generally we don't recommend, baby aspirin, that's what we recommend most of the time. And some of the trials have shown protection, if the person has high risk, in terms of other risk factor, like a family, somebody died like in 50s, they have high blood pressure, diabetes. Again, for everybody to take aspirin, no. So in the trials, what the recommendations are, what it shows that aspirin, so we are going to balance what aspirin is going to cause, what are the side effects. It's like going to cause gastritis, esophagitis, may cause GI bleed. It's going to protect against the heart attack and stroke for sure, okay? But again, if you balance with those side effects, again, you don't get too much gain for the buck in a low risk population. And aspirin in women has shown to decrease the stroke, but in a low to intermediate risk patients, it does not prevent against heart attack. But if somebody gets a stent or is too at a high risk, I would consider giving aspirin. Absolutely. You have to, again, this is for if you have gastroesophageal reflux disease, known history of ulcer, then we have to, that's why the doctors are there to evaluate your complete history and make recommendations. So, all right, any other questions? Please.
So, can you get high blood pressure from too much stress?
Absolutely, absolutely.
Because I think that's right. So, if when the children get, if she had it because of stress,
Mm-hmm.
I mean, then, genetics,
Sure.
stress is not a part of genetics, right?
No, I would disagree. Again, the high blood pressure, even the stress, we don't have, that much like genes exactly, but high blood pressure can definitely be familiar. And if somebody is getting high blood pressure just because, how you know that? How you are going to prove that this person has stress-related high blood pressure? It's hard to prove. That person is predisposed because of its genes. 95% of the high blood pressure cases are idiopathic. We don't have any clear, but we know that the high sodium diet, stress, other risk factors, can increase and can be a problem with control of high blood pressure. But again, this depression, anxiety, again there are research ongoing that can be familial too. So, I won't, if somebody has high blood pressure, then, again, if the family history, you should be definitely be at, again, I won't be too much anxious about it, but definitely I am at somewhat risk to get high blood pressure. But again, you can defy that. There are a lot of things that goes into the equation: what you eat, what you do, how much stress, and again, the genes are part of it, and it affects almost everything, in the long run. Not reassuring answer for you.
No, my mom died at 76, so not really. But I think it was family, and I think it was husband, and I could get different people to agree with.
No, I completely agree.
Why-
If you are
Why she had high blood pressure.
sure, so you can again, that's what.
I have a sister that's been nursed
Sure. So if I have a person who has high blood pressure, borderline, I told them just relax, watch your diet. Sometimes you can just control and if your lifestyle is completely different, then again you may not get it, of course.
I would say my lifestyle is a lot more calm.
Absolutely.
And I've been working on getting it calm.
All right, good luck.
Some jobs.
Mhm.
My children are on their own. It makes a difference where you're at in life.
Absolutely, ma'am. All right, any other questions? Please. Mm-hmm. Yes. First of all, it's hard to clear. It's some of the studies show that aggressive control of cholesterol, it regresses, and generally we don't put stents in 20%. No, they won't. There are no guidelines to do that. And one thing, 20% blockage, as I mentioned, that it should not cause a problem. There is enough reserve. So if the blockage is not to 70%, we don't put any stents. Putting stents does not prevent against further heart attacks. One thing that it's life savior when it's done in the setting of a heart attack. It increases longevity. But putting lot of stents, again we refrain from them unless there is a good indication and the blockage is significant. And again, lifestyle changes, control of diabetes, high blood pressure, cholesterol, smoking cessation, all these things are going to take care of that 20% blockage. And again, to reassure, lot of population, like a significant chunk will have 20-30% blockages. So that's yes, please.
I think those screens are a good idea.
Which screenings?
They send advertisement all the time for life screening your legs and your heart, miracle things. I've done them before, but I just like to see what they say.
Okay. So there is, I'm coming from Cleveland Clinic where, sometimes you get detected and you detect things that sometimes in some, there is lot of, again, the AHA, ACC won't officially recommend so and so. It will be a huge expenditure on part of the health budget. If we recommend that you should do, routine echocardiogram, if you reach that, you should get routine EKGs, there is no such recommendation. But if you are concerned, if there is, I think the first thing should be a clinical examination with primary care physician. If they feel the pulses are okay, you don't have any symptoms, why to check, if your pulses are okay, you don't have any pain in the leg. You can, let's say you walk for a mile or two every day, then, and you don't have any problems. I don't think there is any, but again, if there is any concerns, if there are risk factors involved, Again, as I mentioned, women can have atypical symptoms or maybe asymptomatic. I think I would leave up to, to the judgment of primary care physician to assess, each patient in holistic, given, better knowing each risk factors and then advise the screening tests.
Yeah, there was screening just not talking about it.
But
It was 100 gallons
sure,
8 years ago, and they checked the neck, and the L center said moderate.
sure. So
Mild
yeah.
blockage.
So for as far as the carotid artery, the screening for that's called the thickness of. So there is recommendation that if the person is smoker and they are, I believe, more than 60 or 65, then they should have a carotid ultrasound done once.
Now, one physician said that if you go to them screening and they find something, well, then you gotta go to the doctor.
Absolutely,
They
absolutely.
think they have to find something, but it might be more on the minor side.
Yeah.
And one doctor said you're kind of stirring up the pot, and whether you really.
That's what I was showing. There are so many, again, the tests are not perfect. It's going to show some minor, it's going to just create unnecessary anxiety sometimes. So that's what my recommendation would be to follow with primary care physician. He knows you better as a person, what are your risk factors. Let him advise what screening tests are needed. And again, that the colonoscopy, mammograms, those are they are clearly established guidelines for those. So I think definitely your primary care physician. But as far as testing for the heart, I would leave up to primary care physician to see when the person requires cardiology referral versus the stress test versus an echocardiogram. No,
There's an article in there, I just got an article about tests that are necessary or unnecessary.
absolutely, absolutely. So that's why they don't come up. It causes lot of, we cannot sustain. If they put a recommendation that everybody at certain age should start getting this, and the test leads to further testing. That's very well known. If you get one test, you are going to get some other testing. Let me tell you that. And so I would leave up to individual care. That's why the doctors are there. That's why, I think. Okay, any other questions? Well, I think that's their, yeah, that's what I would say. I generally tell my patient that don't leave my room or your room until you have all your answers. Don't go anything, don't go, if anything is not clear, please don't leave this room. That's what I generally say. If they don't understand their medications, why this is being given, I think this is a team, that doctor and patient team. That's only going to decide the success. So that's what we do.
I think the regular layperson, the best thing you can do is write down your questions before you get them.
I think absolutely, yeah.
And I've had one doctor, I'd be looking at my paper, that he'd be reading over my shoulder all the stuff I had down, so he knew what I was gonna ask him. And then one other lady, well, she was, well, I said I had some questions, so she said, shoot. So, she wanted the questions.
Yeah.
So
I think that's a good idea to go prepared so that you have.
Well, I guess have them out there visible, so, but I like to do the doctor before I get questions. No, but when you find
Any other questions I can answer for you guys? Well, I hope it was worth it, and thank you again for coming.